Ladies and gentlemen, welcome to today's lecture on Allergy and Immunology in the Step 2 High Yield series. My name is Niket Sonpal. I am the Chief Resident at Lenox Hill Hospital, North Shore LIJ, and Assistant Clinical Professor at Touro College of Medicine. Now, to give you an idea of what we're going to be discussing today in Allergy and Immunology, the first topic is going to be anaphylaxis. That's going to be followed by angioedema, urticaria, allergic rhinitis, and followed lastly by primary immunodeficiency disorders. These immunodeficiency disorders are the bane of every medical student. How to keep them straight? Well, at the end of this lecture, you will most definitely be able to. Anaphylaxis is the worst form of an acute allergic reaction. Physicians are deathly afraid of it because, quite simply, it can cause death. It is synonymous with an immediate hypersensitivity. It starts with an initial sensitization to an antigen. This results later in hypersensitivity. You become re-exposed, you release chemicals, and these abnormalities define the syndrome of anaphylaxis. The timeline of anaphylaxis is very critical for the USMLE. There are a great deal of questions, and it's a very high-yield topic. It starts with sensitization to an antigen. It's then subsequently followed by re-exposure to that very same antigen. Once you're re-exposed, your IgE binds to the mast cell, leading to release of different granules. These granules can be histamine, prostaglandins, and leukotrienes. You might be thinking, well, hey, these are great. These are normal chemicals in my human body. But when you put them together in this method, it leads to the syndrome known as anaphylaxis. Anaphylaxis is characterized by hives, itching, constriction of the airways, and a swollen tongue. You begin to feel short of breath. You'll be audibly wheezing. You'll have some tachycardia, palpitations. Your chest will feel tight. You'll have nausea, vomiting, diarrhea. You'll begin to feel faint. The room will spin. You'll have the sensation of dizziness. Lastly, you vasodilate, and so you become massively hypotensive. If you're not close to a hospital, if you're not close to an EpiPen, what ultimately results is death. There's something known as pseudo-anaphylaxis or an anaphylactoid reaction. And if you can see me, I'm making air quotes because it's a type of anaphylaxis that actually doesn't really involve an allergic reaction, but it's simply just due to direct mast cell degranulation. What happens here is there's no pre-sensitization to the antigen. It's not even IgE related, but it's treated exactly the same. So what basically happens is this antigen comes in, touches the mast cell directly, and boom, you have release of prostaglandins, leukotrienes, and histamine. Now you might be wondering, how do I prevent anaphylaxis? You're a physician, you want to do right for your patients, but you also want to know the causes of anaphylaxis because they're going to ask you on your boards. The cause of anaphylaxis is anything that can cause an allergic event. Insect bites and stings are very common. Medications tend to be the most common in hospital settings. Foods are the most common as an outpatient. The most common currently in children that you hear about on the news is peanut allergies. Why are peanut allergies on the rise? Is it because we're testing more for it and the incidence is growing and prevalence is growing as well? Or is there something in the human nature currently that is triggering more peanut allergies? That's really neither here nor there, but it's food for thought. Latex is a very important cause of anaphylaxis in healthcare workers. You have to be very, very concerned because we use latex for everything. Our gloves, our face masks, even for the Foley catheter that's inserted. So you have to be very careful. Now we've just gone through a variety of symptoms the patient will have when they have anaphylaxis. But there are 4 hallmarks that you must be able to pick out of the vignette during the USMLE to be able to characterize anaphylaxis. These 4 hallmarks are hypotension. Normal blood pressure is 120/80. These patients will be dramatically low at 60s and 70s systolic. They will have tachycardia. When you listen to them breathe, you'll hear upper airway stridor. That means there's a narrowing of the upper airway. That means their throat is closing up. That means if you don't get an airway soon, you're going to be in deep, deep trouble. And lastly, you're going to notice that there will be a rash. This rash will be red, itchy, raised, indurated. Now you may be wondering to yourself, what do I do if a patient walks in and he looks like he's got those 4 hallmark signs? How do I treat them? Well, the best initial treatment for anaphylaxis is actually, as always, maintain the ABCs. First, ensure that there is airway protection. That could be through intubation. If it's already closed off, then you may need to do a cricothyroidotomy. Followed by breathing, ensure that the patient is receiving adequate respiration and ventilation. And lastly, the circulation. How do you maintain the circulation? Remember, with vasodilation from this anaphylaxis comes the hypotension. Therefore, epinephrine is the first best line treatment for somebody with anaphylaxis. You can also give them antihistamines, which are broken up into the H1 and H2 category. And lastly, you can try steroids. These steroids can be either methylprednisolone or hydrocortisone, but always remember, the best initial medical treatment should be to follow the ABCs. The best initial medication to be administered is epinephrine for anaphylaxis. Angioedema is characterized as a sudden swelling of a particular part of the body. Remember, it can be hereditary or it can be acquired. It's the swelling of typically the face, the tongue, the eyes, and most importantly, the airway. The hereditary form is when you have a C1 esterase inhibitor deficiency. What ends up happening is people will find that they swell up considerably after some minor physical trauma. What you have to remember, though, is angioedema is often idiopathic. It can sometimes just occur from putting on a t-shirt. Patients have come in and said they had a pillow fight with their sister and the child's face swelled up. What the high yield point for the USMLE is you want to look for a recent start of ACE inhibitors preceding the symptoms of facial or tongue or eye or airway swelling. This is extremely high yield and the USMLE loves to test for it. Hereditary angioedema is a genetic disorder. What you must remember is that steroids don't work. It is always associated by facial swelling and stridor. But what you must remember is there is an absence of pruritus and urticaria, an absence of itching, an absence of raised lesions on the face or other parts of the body. Now, when a patient presents to you with angioedema, how can you differentiate it from, say, the patient was stung by a really large mosquito? Well, the best initial test for hereditary angioedema is to check a C2 and C4 level in the complement pathway. When the lab returns, you'll notice that they are decreased. The next best test is also to actually check the C1 esterase inhibitor level. This too will also be decreased. What you must know is that there are 3 types of hereditary angioedema. Type 1 exists with a decreased level of the actual enzyme. Type 2 has normal levels but decreased function. And type 3, there's actually no detectable abnormality, but the patient still suffers from an idiopathic form of angioedema. The treatment of angioedema begins with ensuring that there's always a patent airway. Because of the fact that this is such a rapidly evolving process and you can lose the airway within minutes, you must ensure the patient is either A, breathing on their own, or B, intubated and you're helping them maintain the airway. In acute treatment, you can use fresh frozen plasma or a medication known as kalinitide. In a long-term treatment, what's been shown to be effective has been androgens known as danazol or stanazol. For patients who are suffering from angioedema secondary to ACE inhibitors, the best next step is, exactly, remove the ACE inhibitor. Remember, angioedema from ACE inhibitors is due to the accumulation of bradykinin. This bradykinin accumulates and leads to the symptoms that we have just described. Urticaria is a form of allergic reaction that causes sudden swelling of the superficial skin layers. It can be caused by insect bites, certain medications, applied pressure to the skin, cold temperatures, and even vibration. Here's an example of a patient who has urticaria. Note the superficial swelling, the erythema, the raised lesions, and if you could feel it, you'd notice induration. The best first-line therapy for urticaria is antihistamines. These work by blocking the H1 receptor, which is actually very crucial in the development and release of histamine from the mast cells. These are known as hydroxyzine, diphenhydramine, fexofenadine, loratadine, cetirizine, or even ranitidine. For those of you who suffer from allergies, these names are household. The next line of therapy are known as leukotriene receptor antagonists. These block specific leukotrienes such as the D4 and the D3. These are involved in bronchoconstriction and the discomfort that's involved with urticaria. These names are montelukast and zafirlukast. What you must also note is that urticaria can be so bad that people can actually write on their skin with their hand or nail or an object, and the skin responds in that line. This is known as dermatographia, as seen here in the image. But do keep in mind this is not advisable for test day. Allergic rhinitis is an allergic reaction and inflammation of the nasal airways. It occurs when an allergen, most commonly pollen, dust, animal dander, is inhaled by an individual with an already sensitized immune system. The allergy then triggers the production of the antibody known as IgE, which subsequently binds to mast cells and basophils containing histamine. This is what also is commonly referred to as hay fever. What happens is patients will present with recurrent episodes. The symptomology will be watery eyes, sneezing, itchy nose, and itchy eyes, most specifically first thing in the morning. If you look inside their nose, they'll have an inflamed, boggy nasal mucosa. The turbinates will be pale or even violaceous. And lastly, there's a high association with nasal polyps in patients who have allergic rhinitis. The way to diagnose allergic rhinitis is quite simply through clinical exam. The clinical diagnosis with current episodes, the presentation, can pretty much cinch the diagnosis. However, skin testing and blood testing can be done. When you have blood tests, you'll notice that the IgE levels may be elevated. You can actually send nasal discharge for a smear, and you'll notice an increased number of eosinophils. And as I mentioned, skin testing can be done where the skin is made into separate quadrants and squares, and then little pricks of a needle with the actual allergen are introduced into the subdermis, and a reaction is looked for. The treatment of allergic rhinitis has 5 steps in it, but remember, an ounce of prevention in this case is worth a pound of cure. When working with allergic rhinitis, you want to prevent and avoid the triggers. So patients are advised to close windows and use air conditioning to avoid pollen, get rid of animals to which the patient is allergic, so bye-bye fluffy, cover mattresses and pillows, and use an air purifier or even dust filters. The second step can then be to start with an intranasal corticosteroid spray. Then you can try using antihistamines, known as the H1 specifically. These are loratadine, clemastine, fexofenadine, bromopyramine. Then you can try intranasal anticholinergic medications. This is specifically known as ipratropium. And lastly, you can flood the patient and desensitize them to the allergens that cannot be avoided. And so over time, their body develops immunity towards it. Now we're going to switch gears and start talking about the primary immunodeficiencies. These immunodeficiencies always cause medical students trouble, but after the next few slides, you're going to have them down packed. They're a favorite of the USMLE, but after this, you will have no trouble with them on the exam. The first one we're going to discuss is called common variable immunodeficiency. In this syndrome, B cells are present, but they have a decreased output of Igs, meaning the immunoglobulins. There is a global decrease in all subtypes. This includes IgG, IgM, and IgA. So remember, when you're questioned about common variable immunodeficiency, you're going to have low B cell output, but normal T cells. So remember, the immunoglobulins are low, the T cells are normal, even the number of B cells are normal. They just have the lowest output of immunoglobulin. As a clinician, you might be wondering to yourself, how will a patient with this syndrome, CVID, present to me? Well, they're going to present with recurrent sinopulmonary infections in adults, that's distributed equally amongst genders, they're going to have frequent episodes of bronchitis, pneumonia, sinusitis, and otitis media. Other manifestations actually do include giardiasis and a sprue-like intestinal malabsorption. What you'll also notice with these patients is that they have an increase in autoimmune deficiencies and diseases such as pernicious anemia and even seronegative rheumatic diseases. So if a patient presents to you with chronic pneumonia, or for some reason they've just developed giardiasis after a single trip to somewhere with normal water pollution, they come back and now they have these symptoms, start thinking about CVID. The USMLE loves to trick us up and ask us the differences between the primary immunodeficiencies, and this tip is very high yield. Remember, the clue to common variable immunodeficiency is a global decrease in the output of B lymphocytes, but a normal number of B cells. In addition, what you must remember is that there's a normal amount of lymphoid tissue. That means the adenoids, the tonsils, the lymph nodes themselves are all normal in size, adequacy, and number. What you must also keep in mind for CVID is that there is a marked increase in the risk of lymphoma with patients who have a long history of this deficiency. At this point, you're now suspecting that a patient has CVID. They've had recurrent sinus infections, recurrent pneumonia. Well, how do you test them for it to confirm the diagnosis? Well, there are two ways. The first way is to actually check the actual immunoglobulin level, and in this what you'll notice is that the immunoglobulin levels of IgG, IgA, and IgM are decreased. Another way is an antigen stimulation test. What you do here in the antigen stimulation test is you quite simply present a B cell with an antigen. What you'll notice is that they have a decreased response. They're sluggish. They're not doing what they're supposed to do. Their output of actual immunoglobulins is decreased. But that test will also tell you that there were a normal number of B cells. So your patient presented to you. They had recurrent pneumonia. You went ahead and did their immunoglobulin level. They were decreased. So now you pretty much know this patient has CVID. So how do you treat them? Well, there are two arms to the treatment of CVID. The first is simply antibiotics that are used for each infection as it develops. If they have community-acquired pneumonia, considered ceftriaxone and azithromycin. The next arm is something considered chronic maintenance. The patients lack IVIG, so what we do is we give them regular infusions of IVIG to maintain adequate blood levels. You see, this disease is one where you don't have enough immunoglobulin, so we're simply replacing it. Our next primary immunodeficiency disorder is X-linked, or originally known as Bruton's agammaglobulinemia. It's quite a mouthful. This is basically low B cells, normal T cells in young male children. These male children will present to you with an increased frequency of sinopulmonary infections. What you'll notice in testing is their B cells are diminished in number, as is the lymphoid tissue. Now this is in striking comparison to CVID, which had normal numbers of B cells and normal lymphoid tissue. X-linked agammaglobulinemia has low B cells and low lymphoid tissue. That means there's a decrease in absence of tonsils, adenoids, lymph nodes, and even the spleen. But when you go through further testing, you'll notice that their T cells are normal. The way you treat them, you give them antibiotics for every infection as it arises, and simply for chronic maintenance, it's long-term regular administration of IVIG to keep the children healthy. Severe combined immunodeficiency. Now this is really the big boy of primary immunodeficiencies. The word combined implies that there is an absence and even deficiency of both B and T cells in this patient. What this means is it's going to result in infections related to both types. So remember, low B, low T on testing means severe combined immunodeficiency. This is almost analogous to HIV. Now let's talk about each individual cell line in severe combined immunodeficiency. In the B cells, what you'll notice is there's decreased immunoglobulin production, leading to recurrent cyanopulmonary infections, beginning as early as 6 months of age. When it comes to the T cells, there is marked decrease in the number of T cells overall, giving many of the infections that you would actually see in somebody who had AIDS, such as PCP, varicella, and Candida. Besides treating the infections, these patients must go on a long-term treatment plan, which is typically a bone marrow transplant and can be curative. In the last few primary immunodeficiency disorders, we've discussed a decrease in either a B cell line or a T cell line, but this is IgA deficiency. This is very different. This is actually a lack of a particular type of immunoglobulin. These patients present with recurrent cyanopulmonary infections. Based on just that fact, if they tell you that on the USMLE, you have no idea what it is. IgA deficiency is one of the most high-yield primary immunodeficiencies because the USMLE loves to test on it. So if they constantly present to you with recurrent cyanopulmonary infections, how do you know what it is? Well, they have to give you other clues. One clue is they could tell you that the disease has another type of atopic disease, some kind of skin infection. But the one kicker that will always cinch the diagnosis is the patient develops anaphylaxis to blood transfusions when the blood donor has a normal level of IgA. They may also have a concurrent sprue-like infection or fat malabsorption. They also have an increased risk of vitiligo, thyroiditis, and rheumatoid arthritis. Say you had a patient present to you who was anemic. You gave them a blood transfusion and they went into anaphylaxis. You're able to stabilize them, but what do you do long term? Well, they will have recurrent cyanopulmonary infections, so you must treat the infections as they arise with antibiotics. For future blood transfusions, they must be washed packed red blood cells. IVIG actually does not work because the amount of IgA in the product is actually too insignificant to be therapeutic. And in fact, the trace amounts of IgA and IVIG will actually provoke the same anaphylaxis that blood transfusion does. Why is that? Well, your body has no IgA if you have IgA deficiency. And if I introduce it, it's actually now considered to be a foreign antigen. Your body then reacts violently to it in an anaphylactoid type manner. Hyper IgE syndrome is another immunodeficiency that is relegated solely to a particular type of immunoglobulin. These patients will present with recurrent skin infections, not cyanopulmonary, but recurrent skin infections, most commonly due to staphylococcus. The way to treat these patients is you treat the infections as they arise with anti-staphylococcal medication, and you can consider a prophylactic antibiotic such as dicloxacillin or cephalexin. A typical staph infection will look like this. It looks something like a pimple, but they can be larger, more deep, and what to keep in mind that the hallmark of a typical staph infection, not always, is a pustule, just like that. Wiskott-Aldrich syndrome is a very tricky one. It actually throws everyone off because it has a normal number of T and B cells. The reason you're immunocompromised is they decline with age. So how do you get the question right on the USMLE? Well, you want to look for an immunodeficiency that's combining both a presentation of thrombocytopenia, low platelets, and eczema. Another clue is that the T lymphocytes are markedly diminished in both the blood and the lymph nodes. Lastly, if they ask you about treatment, the best way to treat Wiskott-Aldrich syndrome is bone marrow transplant. It is truly the only definitive treatment. So remember, the tip for Wiskott-Aldrich syndrome is a normal T cell count, a normal B cell count. They just decline with age. Chronic granulomatous disease is exactly what it says it is. It's chronic granulomas. The disease results in extensive inflammatory reactions, and they can be all over the body, including, and most specifically, the lymph nodes. The lymph nodes, when examined, will have purulent material leaking out. Patients with CGD also are at a higher risk of developing aphthous ulcers, and inflammation of the nares is common. What does an aphthous ulcer look like? Well, somewhere along the buccal mucosa or on the inner lip, you'll notice this ulceration. It's very painful, it's aggravated, it's like a really bad canker sore, but just much more painful. Patients with chronic granulomatous disease may also present with obstructive symptoms in the GI or urinary tract. That means they may come in with symptoms of partial or complete bowel obstruction, or they may have decreased urine output with a very, very large cystic mass somewhere in the lower pelvis. That cystic mass is actually their bladder from not being able to drain properly due to the chronic granulomas. Another hallmark for diagnosing these patients is you want to look for an infection with an odd combination of staph, Burkholderia, Nocardia, and Aspergillus. The best diagnostic test for chronic granulomatous disease is an abnormal nitro-blue tetrazolium testing. What this test does is it detects the decrease in the respiratory burst that produces hydrogen peroxide. That means the lack of NADPH oxidase, which generates superoxide. In this test, in CGD, the test is negative. It's not a positive test. It's a negative test, meaning that the actual paper that's used does not turn blue. Remember, in chronic granulomatous disease, the test is negative and the paper does not turn blue. As we come to the close of primary immunodeficiency disorders, I want to review them all with you. CVID is one where you have low B cells, but a normal number of T cells. X-linked Bruton agammaglobulinemia will also have low B cells and a normal T cells, but you can distinguish it because it's going to be in young male children. SCID has low B and T cells, so this is analogous to HIV, and you're going to see similar presentations, such as with PCP or toxoplasmosis. IgA deficiency is going to be anaphylaxis with a blood transfusion. Hyper-IgE syndrome is recurrent skin infections with staphylococcus that look like large pimples. Wiskott-Aldrich syndrome is normal T cells, normal B cells. They decline with age, but you're going to look for low platelets, thrombocytopenia, and eczema. And lastly, CGD is when you're going to have recurrent infections of the lymph nodes that drain purulent material. You're going to have infections such as staph, Burkholderia, Nocardia, and Aspergillus. Thank you for joining me in the Step 2 High Yield series for Allergy and Immunology. I'll see you next time.